hyperkalemia. So the reason why we choose this topic is because still many people don't understand the indication for lactic cocktail. There's one. Number two, some of them don't know which medication need to be given first, and then based on the guideline, and also what should you expect? How do you monitor patient with hyperkalemia once you give the insulin chase? Okay, without further ado, I would like to invite Dr. Rafidah to give her talk.
Okay, thank you very much, Iskandar. And I think I'm not too sure whether I'm going to answer all your questions, but I'll try my best. Maybe we can have question and answer after that if there's any questions that you want to ask. So basically, thank you for being with us this evening. It's a very important topic. I think we had a chat earlier on as well, because we said, not everybody understood what Lytic cocktail is. I think you did an audit, isn't it? In the hospital you worked in before, because the houseman say something different, the medical officer say something different, the nurse say something different. So what I'm going to do today is dia macam tak bagi berjalan pula. Sekejap. I punya ni macam stuck. Sekejap
Okay, sure. So while Dr. Rafidah is try settling her slides, I just want to share, actually previously we did an audit. This one is 3 years back when I was in the hospital Putrajaya. So suddenly one of the consultants asked me to do an audit just to see whether the houseman, the nurse or the MO understand what is lactic cocktail. So surprisingly, actually the nurse, everyone knew what is lactic cocktail, how to prepare it, but they never give the medication to the patient. It was given to the houseman. And then the houseman, actually most of them actually don't know what is inside the lactic cocktail. So, and then we also did audit towards the medical officer. Most of them have the answer right, what is the ingredient for the lactic cocktail. However, most of them didn't understand, didn't know actually which one to be given first. So this is our aim, so that all understand the indication and how to prescribe the medication.
Right. Thank you, Isa. Sorry, my slides boleh jalan. So basically, the objectives of today, I want to make sure that everybody knows that the Lytic cocktail does not exist. And this term should not be used at all. So, and the second objective, I want people to understand, those listening to understand the potassium, a little bit about potassium homeostasis, and be familiar with the approach and treatment of hypo and hyperkalemia. So just to go to the Lytic cocktail story, this is going to be my outline of the talk. We'll let you know, tell you a little bit about potassium and the causes, the symptoms, the signs of hyper and hypokalemia, a little bit of treatment and conclusion. Okay, so I think everybody seems to be using Lytic cocktail. Apa dia Lytic cocktail ni? So kalau you Google, actually, this is the answer you get, Lytic cocktail is a mixture of drugs used for women with eclampsia. So they are usually chlorpromazine, promethazine, and pethidine. That's not what we kind of know. So actually, this term Lytic cocktail for the treatment of hyperkalemia does not exist. So I want to make sure that you if you don't remember anything else, just remember, do not use that term at all. Okay. So again, I go to the PubMed. When you do your literature search, you put Lytic cocktail hyperkalemia, you search, there's 0 results. So there's nothing. Right, so I don't know what everybody in Malaysia has been trying to manage and plan and put Lytic cocktail. Basically, in a nutshell, the term Lytic cocktail is a myth and it does not exist. So I think from now on, I hope that you can actually stop using this. Right, this term does not exist. So if you talk about cocktail and hyperkalemia, okay, this is a very interesting. I look back, in the history. Apparently, in 1954, they did use some sort of term cocktail, combination cocktail in the treatment of hyperkalemia. But, this was a nice article actually that I found containing, look at the amount, 400 ml, 25% dextrose, 50 unit insulin, 50 millimoles sodium bicarb, right? So this was effective in controlling hyperkalemia in patients with traumatic acute kidney injury in soldiers. Basically, this is rhabdomyolysis. So another publication is from the US when they had actually made up their cocktail. So it is called Hyperkalaemia cocktail. So memang dah buat benda tu. So it contains dextrose 30%, 50 ml, yeah, regular insulin, calcium, glucose, and acetate. So it's a made up one. So I don't know, when we say our Lytic cocktail, I don't know what we mean at all. So basically, so the issue about this, because it's so commonly being misused, it's kind of a common practice, but we are too complacent on just putting in the plain Lytic cocktail, but nobody knows what it means. Macam Iskandar kata, you know, the houseman understand differently, the MO understand differently, probably the specialists understand differently as well. And you know, for me, I don't understand at all. You know, and there are reasons, actually all the treatment, there are reasons why it's given. So nobody knows what the reasons are, and they just put Lytic cocktail, which is not right. And when you put in the notes, you don't prescribe properly, and this is when the time comes when the medical legal problems will come in. So I think we have to change our practice, like from now on. Okay, so let's talk about the basic physiology of the potassium. I'm sure a lot of people know how the kidney looks like. And each of your kidney has got about 1 million nephrons, and each nephron has got glomerulus to filter, yeah, and basically the glomerulus is actually, it's like kilang penapis, it filters out, and then all this will come out this way, and all the toxins will be removed, and all the good things will be reabsorbed again. So all the waste and the extra water will become urine at the end, of course, yeah. So this is how it is for those obviously all the students and all that will probably understand what basic physiology of this is. Okay, renal kidneys and nephrons is very important. You know, it filtrates about 180 liters of water per day, and it excretes potassium, and it maintains the potassium is important to maintain effects on the heart, basically. Of course, it does everything else. Yeah, and with regards to potassium, the most abundant cation is in the intracellular fluid. And, you know, it maintains proper distribution of potassium across the cell membranes. It's very important in normal cell function. Long-term maintenance of potassium homeostasis is achieved by alterations in renal excretion of potassium in response to variations in our intake, right? And understanding the mechanism and regulatory influences governing the internal distribution and renal clearance of the potassium under normal circumstances, then we will know when we approach disorders of potassium and what is commonly encountered in clinical practice. Okay, I mentioned just now, potassium is a major cation, ion with a positive charge in the intracellular fluid. Only 2% of body potassium is found outside the fluid, which is the extracellular fluid. 98% of potassium is in the cells. It affects the body cells, nerves, muscle function, and maintains cells electrical neutrality, osmolality, neuromuscular transmission, nerve impulses, assisting skeletal muscle contraction, electrical conductivity, and it affects the acid-base relationship to the hydrogen ion as well. So in a normal balance up here, the potassium intracellular fluid is a lot more, which is around here. This is the intracellular fluid. Is greater than the extracellular fluid, which is the intravascular here. So basically, hydrogen ion is not that high, it's quite low. But when you have acidosis, the hydrogen ion content in the extracellular fluid, which is here, increases, and the ions move inside the intracellular. So to keep everything balanced, the potassium has to come up from the cell and go into the bloodstream. That's why the potassium in the bloodstream is high, basically causing hyperkalemia. On the other hand, when you have alkalosis, more hydrogen ions in the intracellular fluid than the extracellular fluid, then the hydrogen ion moves from intracellular fluid, hydrogen ion here, will move into the extracellular fluid intravascularly, and the potassium had to go out. So that's why you have a hypokalemia here. That's the reason why you have hyperkalemia and acidosis and relative hypokalemia in alkalosis. So the normal serum potassium levels for those who, obviously we know is around 3.5 to 5. Some labs go up to 5.2. But as I mentioned again, the intracellular fluid has 98%. This is the extracellular fluid, intravascular as well in here, which is about 2%, 70, so around this 3.5 to 5.5 milli equivalent per liter. So mostly the intracellular fluid is in the muscle, liver, and the red cell and the bone. Okay, so what happens? The usual potassium intake is about 100. The renal is excreted maybe around 80% of the excretion is in the kidney. So the potassium is also excreted from the GI, smaller amount, but mainly is excreted in the kidney. And of course, there is a cell shift between the extracellular fluid. So basically, let's go to the hypo and hyperkalemia, right? So let's go to hypokalemia first. Okay, the definition of hypokalemia is serum potassium below 3.5. So in a moderate hypokalemia, you get around 2.5 to 3.5. But the definition for severe hypokalemia is less than 2.5. There are various causes, right? Number one, whether the intake is less, right? Whether you're not eating very well, you're malnourished, or you need TPN, it's not enough potassium, you need, and so on and so forth. Number two is actually loss, right? You just now the GI, you lose your potassium in the gastrointestinal tract. So when you have diarrhea, you have vomiting, you have a lot of loss, right? You have chronic laxative abuse, one of them, and also you have diuresis. Say if you produce so much urine, for example, you have glycosuria, renal tubular acidosis, all these Cushing syndrome. Those are lesser common things, yeah. And those drugs as well, there are drugs that medications, yeah, that actually reduces the potassium excretion, which is your diuretics, your thiazide, furosemide, your steroids, your insulin, cisplatin, yeah, certain antibiotics, especially this one, amphotericin B. I think I see quite often excessive insulin, beta agonist. And other diseases, you see your hepatic disease, malabsorption and butter and things like that. So those are the reasons why you get hypokalemia. But this is the ones that, your my MOs and my housemates all really like to, ask. Maybe they come out in MCQ of PACES, maybe Iskandar will update me. The last time I set for MCQ was like 1,000 years ago, MCQ, MRCP. So this is, where you have a type 1, type 2, and then type 3 and type 4 RTA. RTA type 4 is actually hyperkalemia, which is more common in diabetic kidney disease. But these ones, I think we see quite regularly. It's just that we're probably not diagnosing properly. But the type 1 RTA is basically distal nephron problems, where you have impairment of the proton secretion in the distal nephron. Okay. You get hypochloremic metabolic acidosis with normal serum anion gap and hypokalemia. So the treatment is actually this show solution. I think you're quite used. This is the component of solution. Okay, and also some patients will need potassium as well. So type 2 RTA is the proximal tubular problems, where you inability to reabsorb back the bicarb, right? So you cause acidosis, acidemia. And because of that, the urine pH, you get the same thing, hypochloremic metabolic acidosis with normal serum anion gap and hypokalemia. Fanconi, I've only seen a few in my life, not that common, I think, or is it probably we are probably not diagnosing it fairly well. And what I see quite often as well is amphotericin B induced distal RTA. I think I've seen quite a lot causing hypokalemia. So the treatment is here. So if any of my MOs who's listening or housemate would like this document, I can give it to you, or anyone as well. You can email me later. This is a very good summary of renal tubular acidosis by BMJ. So the signs and symptoms really depends on the severity. If you have mild hypokalemia, you won't feel anything. But of course, if you get severe hypokalemia, you have skeletal muscle weakness, you have periodic paralysis, you have paresthesia. I've seen quite a few that causes even rhabdomyolysis from severe hypokalemia. And of course, you have very silent ECG changes, and all these other things, other symptoms are there, but not that common as above. Basically, they are asymptomatic. So for ECG, the earliest ECG change is a decrease in the T wave amplitude. For those who don't know, this is a T. So as the levels of potassium decline further, the ST segment depression and T wave inversions are seen, right? It will go down, right? While the PR interval can be prolonged, which is PR interval is prolonged along with an increased amplitude of P wave. Subsequently, when it gets a bit bad, you see a U wave, which is this one. it's a positive deflection after T wave, right? Okay, so it's mostly seen in the precordial leads, which is V2, V3, V4, like that. So if it's really severe, the T and the U will fuse and you get the giant U waves. So and they can cause other types of tachyarrhythmias as well, VT, VF, and all that sort of thing as well. So I've seen those as well. So this is a they published this case. I think it's quite nice. ECGs. This is a 21-year-old man who presented with potassium 1.6. There was a prolonged QT interval, and ST segment depression and U waves. Whereas after this ECG is after they gave some intravenous potassium replacement from 1.6 to 2.5, slight improvement, less prominent pre-wave, but still slightly that slightly decreased QT prolongation. So this is the treatment of sorry, go back. Okay, that was the treatment of hypokalemia. So you see the ECG changes changed. So let's go to hyperkalemia, right? And durian, I know you guys like durian. Durian has been proven to induce hyperkalemia. So this publication was in Medical Journal of Malaysia, where an end-stage kidney disease patient decides to take, I don't know what sort of amount of durian, I'm not sure, but the potassium was 9.1 when he presented with sine wave ECG here, which is not very clear, but you can dig up this publication back in 2011. I think it's been proven by a case report, so to speak. So these are the durian simulates durians, but these are the fruits in Malaysia, which has quite a bit of durian, potassium, durian, banana, jackfruit, papaya, honeydew, grapes, and so on. So these are the things by right our kidney disease patients, so chronic kidney disease should avoid. But then again, it's very difficult. Easier said than done. I think last week we had a patient with chronic kidney disease with creatinine around, I think 200-300, but he decided to take lots and lots of durian. His baseline potassium was normal and he came with potassium of 7.5. So, despite giving medical treatment, it was very difficult to bring down the potassium. So we had to do one dialysis. So, there's not much point. The dietary alone is not enough to cause severe hyperkalemia if you don't have problems with excretion. Like, if you take a lot, usually your kidney can remove. But if you have lots of dietary potassium intake, but your kidneys are not working normally, that is the problem when you have complications such as this. So just now I played this video in my Facebook, so you can also go there and this is when I advise my kidney disease patients to actually really cut durian, or of course they actually, one of them here is actually a patient, so she didn't touch the durian at all. So it was very good, and this is something that is difficult, but it's something that is an ongoing battle to educate our patients. Okay, so definition of hyperkalemia is a problem, I would say problem, so to speak, because not everybody agrees the same definition. And if you look at in the literature, there's so many different levels that people actually suggest. So like Lewinsky, more than 8, 7, 6.5. So exactly what is it? Okay, so by definition, this is by the BMJ definition, the hyperkalemia is actually anything above 5, fair. And significant hyperkalemia, which is, the normal range is 3.5 to 5. So anything above 5 is high lah. So significant hyperkalemia is defined as serum potassium value more than 6, right? So between 5 to 6, moderate or mild, they're moderate, we call it moderate, 5 to 6. And usually, clinical manifestations of hypokalemia are not common with values less than 6, actually. Yeah. So in Putrajaya, we've decided to label our severe hyperkalemia as serum potassium of more than 6.5, right? So that's the level we're using. So what are the signs and symptoms? Again, clinical manifestations of hyperkalemia really uncommon with values less than 6. Yeah, you have your muscle weakness, you have your paralysis, yeah. But but usually what it does, it causes cardiac arrhythmias. Yeah. So again, we look at the causes. basically, I mentioned just now, if you have increased intake of potassium with decreased renal excretion, when you have your kidney disease and so on, that's when you have hyperkalemia. You have decreased cellular entry of potassium or increased exit of potassium in the cells, your acidosis and all, and something called pseudo-hypokalemia. So these are the ECG changes in hyperkalemia: tall peak T wave, loss of P wave, this is tall T, and subsequently you have widened QRS with tall T wave. So in detail, hyperkalemia decreases the transmembrane potassium gradient, leading to increased potassium conductance, and this shortens the duration of the action potential, right? That's why it becomes like that. So as the serum potassium rises to 5.5, 6.5, you get your peak T wave, yeah. Prolonged PR may be seen, yeah. And subsequently, progressive widening of QRS complex, Van der branch block, sine wave, and then of course you have your asystole lah. Stop reading, the heart stop completely. But ECG, there has been a publication I just read, is insensitive in assessing severity of hyperkalemia. It's quite interesting as well. So yes, I agree, because most of my patients that I see, they don't really have ECG changes, even at potassium more than 6.5. Profound hypokalemia can occur without ECG changes, I mentioned, and this I have seen quite commonly, actually, severe bradycardia caused by hypokalemia. So this is the ECG changes of hypokalemia. Severe bradycardia, AV block, and subsequently, if you look at long lead 2, and you know, it become wider and wider complex. This is wide complex tachycardia. Iskandar is a budding cardiologist. He's going to tell me if I'm wrong, but I think nephrologists only know this part of reading of ECG. And subsequently, you will evolve, become a sine wave like that. So this is a tall T. Tall T. I always tell my doctors, if you know, you just imagine it's like a 10. You know, you imagine you sit on it and you'll be very painful. You know, the T is so tall. You know. So again, what are the causes, right? What are the causes? The decreased excretion of potassium means the kidney cannot remove the potassium. Okay, so this is when kidney injury, chronic kidney disease. And then number 3 is drugs. You know, we need to look at the medications the patient's on or has been taking. So things like potassium sparing diuretics, spironolactone, usually I suggest, you know, especially those with CKD, elderly, please don't give spironolactone. It's very difficult when they get into intractable hyperkalemia. Non-steroidal anti-inflammatory drugs, you know, your Voltaren and all that, causes hyperkalemia. This I see quite recently, especially in ICU these days, when we're dealing with COVID-19 patients and we have, you know, all these secondary infections, you know, nosocomial infections, and we needed to give Bactrim from the kidneys being okay, and they get severe hyperkalemia, severe hyperkalemia, and sometimes we need dialysis just for that. So I've seen that quite regularly these days. Other things like ACE inhibitor, angiotensin receptor blocker, those are the things that commonly used when you treat your patients, yeah, with proteinuria and diabetic kidney disease. So I believe, I hope the guideline says for these patients especially, when you start your ACE inhibitor ARB, you should check the RP within a week or within 2 weeks. Yeah. But please, I need to remind you, please don't tell your patient, okay, we need to check your kidney function in 2 weeks. If the kidney is worsening, we're going to stop the ACE inhibitor. So this is the problem happens when we tell them. They think we're giving a drug that is going to cause harm to the kidney. It's not that. Just try to tell the patients that that is not the reason why you do that, because the renal function will drop a little bit, the GFR will drop a little bit with ACE or ARB. That's what we want, because we want to reduce intraglomerular pressure. So the afferent arterial will be slightly constricted. So the reason why we do renal profile is to make sure that we don't miss renal artery stenosis, which is something reversible we can actually address. Yeah. So typically in ACE inhibitor is actually small, the changes, the increase in potassium, but it really depends on, it's dose dependent and linked to the level of the renal function actually, right? So the other ones are heparin. Heparin causes hyperkalemia. I've seen that quite a bit. And those who deal with transplant patients will know there are calcineurin inhibitors like cyclosporin, tacrolimus causes hyperkalemia as well. What about the second one, which is decreased cellular entry of potassium and increased cellular exit? Those are with the acid-based abnormalities like metabolic acidosis. That's the reason. And the other one is when you have hyperosmolality, like diabetic ketoacidosis, things like hyperosmolar, diabetes, hyperglycemia, and all these things. And that's why when you have hyperkalemia at the beginning of presentation of DKA, diabetic ketoacidosis, you don't jump straight to dialysis, because giving insulin, giving everything, it will reduce the potassium on its own. Okay, so another one is insulin also will reduce the potassium, so the beta agonists as well will facilitate cellular entry of potassium. These are the things that also causes hyperkalemia. Not really seen strenuous exercise cause severe hyperkalemia, but I've seen quite a bit with rhabdomyolysis and tumor lysis syndrome. So that's quite common, resulting in significant hyperkalemia. Right, how do you approach hyperkalemia? Right, so hyperkalemia can be difficult to detect clinically because symptoms are quite vague, yeah, and for most part, it's like an incidental lab finding, right? And history, how do you find the source? I always mention, I always show it to my doctors. The history is the most important, most useful in identifying why the patient has got hyperkalemia. Most of the time, I will look at the charts, look back why, whether they've suddenly given IV potassium or things like that. So another thing is it could also be detected based on just the history alone. So once you take a good history, you'll probably get the answer why the patient is hyperkalemic in the first place. So again, step by step, good history taking, clinical examination, rule out your pseudo hypokalemia, which is not common, I guess. Or this is like when you keep the blood overnight, then of course it will be hemolysis the next day, it will be lyse, your potassium will be spuriously high, something like that. This is so when you rule that out, you have to look at the potassium intake, excretion, where had these patients gone, imbalance. The basic investigation will be full blood count, renal profile, glucose, calcium, and just ECG, right? Subsequent tests, you don't send all the tests, subsequent tests will really depend on your initial clinical findings. Like if you suspect rhabdomyolysis, you do a creatinine kinase, you suspect the patient have got, MVA injury or whatever, status epilepticus or something like that, you do a CK. If you suspect Addison's crisis, of course, quite often, our patients take herbal treatment and all these things, and it can cause that. Is you do a serum cortisol. You do a blood gas to see whether there's any metabolic acidosis. Of course, if the patient is on digoxin, please do a digoxin level, because it might be due to digoxin toxicity. Urine pH when you suspect renal tubular acidosis. And not commonly all these other three, but I do like the transtubular potassium gradient when you evaluate the distal tubular excretion of potassium. I think TTKG is a simple test, but it's not really used, over recent months or even in our local practice. So the differentials, very commonly CKD, when you have hyperkalemia, chronic kidney disease. When you have diabetic, I mentioned, and you have drugs, right? And you have potassium supplementation. Somehow I see a lot of people give Lasix, must give slow K as well. But in the setting of bad renal failure, right? You've got advanced renal failure, you please don't give the slow K as well. And of course, your drugs, your Bactrim or whatever it is that causes hyperkalemia. Uncommonly, you have acute kidney injury, RTAs, your type 4 RTAs, but to be honest with you, I see this quite regularly. Metabolic acidosis and all these other things are not that common, probably uncommon for you, but to me, I see this quite often as well. So what's the treatment? So hypokalemia, of course, you treat the cause, right? Replacement, you're very good at giving IV, KCL, if they are severe, yes, you have to give intravenous. Yeah. So IV KCL is around 13.4 millimoles. Basically, the rate of giving usually about 10 millimole per hour. So around 1 gram per hour. Okay. And never give bolus, and always use infusion. Right. Care must be taken in the setting of acute kidney injury. I've seen quite a lot, and diabetic ketoacidosis, for example, part of the regime is actually give potassium in a drip, but if you have a concomitant severe sepsis, you have AKI, this is when the problem starts. You forget to off the potassium in the drip, and then when they have in the setting of severe AKI, we really cannot, pull back the potassium. Okay, what about hyperkalemia? Usually, this is in reference to our protocol in our hospital. Hypokalemia, if it's less than 6.5 with no ECG changes, it does not require intravenous treatment. Okay, severe hypokalemia, yes, of course, number one, you have to diagnose why and treat the underlying cause. Intravenous treatment has to be done in sequence, right? You have to give slow bolus of 10% calcium gluconate, 10 ml. This is our protocol. So calcium does not reduce the potassium, but calcium antagonizes the effects of hypokalemia at cellular level through the effects of on the threshold potential and the speed of impulse propagation. Basically, it stabilizes your heart, right? And then you give the intravenous bolus of 50 mils of dextrose 50%, okay? Because you need to give insulin. So you give that first. You give intravenous bolus of short-acting insulin 10 unit, bukan 1 mil, it's 0.1 mil in that when you actually draw this up. I've seen people give 1 mil, which is 100 unit, right? So this is serious, so be careful. So, so you move the potassium into the cell. It is active within 15 to 60 minutes and it lasts about 4 to 6 hours. Optionally, you give IV sodium bicarb. It decreases the serum potassium by temporarily shifting potassium into the cells and raises the blood pH. It's effective within 15 to 30 minutes and lasts around 1 to 3 hours. Okay. So at the same time, usually I will give calcium polystyrene sulfonate or oral calamate around 30 to 45 gram daily in divided doses, 15 gram BD or TDS or something like that. So this is very practical issues. I think you need to remember, right? Because I've already banned you all of you, from using the term Lytic cocktail. So how do you document, right? The documentation must be, okay, this patient is for medical treatment for hyperkalemia. Must be documented clearly in the medical notes and name each and every medication, what is the route of administration, and the dosage and dilution. No abbreviation, please, because people may get this wrong, okay? The prescription must be given for each medication in the regime. Bukan Lytic cocktail saja, you have to spell out IV insulin 10 unit, for example, right? Must be accurate, must be correct. So you have to give the right medication, the right dose, right dilution, the right route, okay? And to prepare, you have to prepare with either the staff nurse, the MO, or the houseman, the houseman must be under supervision, of course. The staff nurse can prepare all these medications, but must be prescribed. Each medication must be prepared in separate syringes and labeled very clearly, right? And the administration, either the doctors or the staff nurses, must recheck each medication that's been prepared by somebody. If somebody else prepares, somebody else must check. If it's labeled, it's okay. If it's not labeled, we're in trouble. But the best is if you prepare, you give. That's easier. And remember, the IV access must be functioning. If you tissue calcium gluconate, for example, we're in trouble. You might get gangrene and all these things. So the other thing that many people like is actually talk about diet in the potassium. Okay, when you have chronic kidney disease, right? These are the food that it's very difficult to say no, you don't take. These are nice things, banana, dates, raisin, grapefruit juice, honeydew, all these things. So these are the things that you can't really take, or maybe you just take small portion, right? You have to advise the patients on what food to prevent to not take or take in a small volume, especially when they have problems with chronic hyperkalemia and chronic kidney disease patients. Okay, so other treatment is your sodium polystyrene phosphate is a cation exchange resin. So basically, it increases these two potassium excretion and use binding to capture fecal potassium. So it will be increased GI loss of your potassium rather than being absorbed inside you. So there are new potassium binders, but I've yet to use them. But they've been over recent years, there have been lots and lots of newcomers, so to speak. And loop diuretics, of course, your furosemide and all that. And of course, dialysis, right? Dialysis is of course, is probably the last lah. You don't want to dialyze if possible. That's why a lot of people ask me, When you refer to nephrologist, very difficult because every patient is different. So for example, okay, so sorry, before I go to the next one, which is a case. So like this is a dialysis membrane for those who haven't seen it. The white membrane is actually, the potassium will filter from your blood, will filter through that, and the potassium will go in your, through the membrane and excreted out. So, when you refer to nephrologists, okay, if a case like this, we're going to cases now, a case like this is very simple and straightforward. And of course, this is probably end-stage kidney disease. These are patients who come in relatively well. They have very little problem, maybe a bit of pain here, a bit of pain there, this and that, a bit of tiredness, maybe the HB was really low. So maybe they come in, it's like that. So that, of course, you need a nephrologist, right? You don't need to ask, yeah. But if your hyperkalemia is because, I just give you an example, if because of your, you gave too much of slow K or intravenous too much, perhaps you need to try a couple of medical treatment of hyperkalemia before you refer to a nephrologist. But if you're in the setting of acute kidney injury, really bad, you need to have dialysis. For example, patients ICU. I don't wait until their potassium is 8 or something. But I have to see the case and decide on treatment, individualized basically. So it's very difficult to say A is treatment for A, B is treatment for B. But there are cases that I try medical management for 24 hours. Say, for example, that patient just now I was telling, he had a background of kidney disease, creatinine 200, potassium is always normal, but he decided to binge on durian, for example. So I was hoping the durian will go off, the potassium will go off in 24 hours of medical management, but it didn't. But some do actually. Some, potassium will go off and they will not need dialysis. So it depends on different individuals and depends on the cost as well. So let's go for case 2. This is quite common. I've got a few cases. So 62-year-old lady, known case of diabetes. HbA1c is like really, really bad. I think a lot of our patients are that way. Creatinine is increasing over the years. So her latest creatinine is 240. Potassium is normal here. And about 2 years ago, it was normal. So with the bad diabetes, of course, the kidney will slowly progress. Yeah, the question is, what do you do with the ACE inhibitor? She's on parenteral 8 for many years. I would continue, right? I would continue this. I wouldn't worry about it. If the potassium remains normal and there's just progressive worsening, I'll just continue. But if she becomes unwell, which is common as well, with somebody who's got this bad control of diabetes, they're bound to come in hospital with sepsis. Say, for example, they have intra-abdominal sepsis. She developed a little bit of acute kidney injury on top of the chronic, the creatinine now 350. So she needed things like CT scan and all these things for investigation, right? So this is the time, actually, you should not be continuing her ACE inhibitor. You should off the ACE inhibitor during ward admission when they come in for sepsis, right? A lot of people forget that. So a lot of times when they come in acute kidney injury, the potassium just cannot catch, when they get acute on chronic kidney injury. So that's the, I would stop the potassium, I would stop the parenteral here. And I wouldn't rush, right, to start. You probably bring her back in about a month later. Say, for example, she recovered well from a sepsis, thankfully. But the creatinine didn't go back to normal. The creatinine is 280, for example, the potassium is 5.2, for example, right? So you can discuss with her whether she's willing to forego her dietary potassium. Say, if for example, she loves the durian, she loves the watermelon and all that, I would not give back her parenteral. I would just say, look, we can't take this risk. And, we'll see how it goes. I'm sorry, your kidney may progress, for example. But if she tells me, look, I'm just going to control it, I've got proteinuria, I want it controlled a little bit more, it will cut down and all that, I will probably restart her back on half the dose that she was on before. So again, this is individualized treatment. It's very difficult to say A is for A, B is for B. Right, for case 2, this is common also. When you have patients whose known case of RPA presenting to ED with weakness and all that, I just want to show you the ECGs of this patient, right? This is also published as well. And running out of medication is common because they are young, they forget, or they cut down on treatment and all these things. It's common. So usually if they are severe, they come in with periodic paralysis. Right, this is the ECG. There is a U wave, V3, V4 here, U wave, right? Particularly lead 4 here. Okay. That time it was 2.1, 2.1, and then somehow the potassium dropped. Didn't realize that the here, then subsequent, this is the ECG, right? This is even worse, right? Prominence of the U wave. Right? Then it drops some more when you have the big U wave here, giant U wave, right? When so when it drops lower than that. So this is how it looks like, giant U wave. Okay. So for all the housemen or in listening, so these are some of the ECGs that we may put out to you in your Viva, quite possibly. So the last case is actually someone who's 34, presenting to ED, shortness of breath. Or this kind of patient these days will probably end up in Sari. And okay, this is a Matsali patient, I guess. She had a amphetamine use, right? So nothing much in the pulse rate is 152, blood pressure, respiratory rate 24, oxygen saturation 95, a little bit of systolic murmur. If you can see this, this is the ECG broad complex tachycardia. The patient was given oxygen, IV fluids, lignocaine, not much change. Then it was acidosis, given sodium bicarb, and then potassium came back, it was 8. Then ECG changed to tall T, and he had renal failure as well. So basically, he had methamphetamine-induced acute kidney injury. He was stabilized with calcium gluconate and bicarb, insulin glucose therapy, not cocktail, right? And he had 1 dialysis. So you can see subsequently he was discharged with normal ECGs and normal Ts. So ladies and gentlemen, I hope I've taught you that actually, I've taught you about potassium basically, but I just want to tell you that the term lytic cocktail does not exist. It's a myth, right? It does not exist, please, right? And do not ever use the term lytic cocktail, ever, right? It is not an acceptable term in the field of medicine. We do not have like a fixed standardized solution. You know, if we have that, we produce that, yes, you can call it, you know, maybe it's a name of label or something. Then you may call it something, but at the moment we don't have that. Mistakes can happen and may happen if you don't write it clearly, right? Please, in the medical notes, I give you an example here. This is what you should write: medical management of hyperkalemia, ABC. You know, this is probably not in accordance to sequence, but you should write in accordance to sequence, right? Okay, and this is the plan. You should write that, right? And spell out the details of the management clearly. Spell out which ones to give first, right? Remember, it's calcium gluconate first, right? And then your dextrose 50, and then your insulin, okay? And of course, you have to monitor the patients, right? Some would say repeat the potassium 1 hour. In our guidelines says you give medical management, you repeat the potassium an hour later, for example. And you also have to monitor the patient's sugar levels, right? Dextrose, because you're giving insulin, yeah. And I've said before that I've seen people give 100 units of insulin, which is you know, you have to be very careful about that. And you have to monitor the sugar, dextrose. And but for my patients, for example, if I know why the hyperkalemia, I don't really need the potassium repeated very often. Usually I will give a plan, like for example, let's go for medical management a couple of times tonight. If it doesn't resolve, yes, maybe tomorrow we can consider dialysis, for example, right? And the other thing that I did not mention inside here is actually what we don't use anymore. Nowadays, we don't use nebulizers, right? Those days we use nebulizers, right? To actually reduce the potassium, right? So your salbutamol nebulizers, your beta agonists. So we don't use that. We don't use any nebulizers these days because you don't want aerosolization and with the COVID and all these things. So we don't do that these days. So I did not mention that at all. So lastly, causes of hyperkalemia and hypokalemia need to be ascertained, and treatment need to be instituted based on the level of clinical picture. I think it's very tough for me to just give you an answer how to manage patient in a different setting, right? It really needs to know why. It needs to go a step-by-step approach, and we need to know what to manage depending on the clinical situation. So this is my last slide before I answer before the session of question and answer. I'm happy to answer any questions. I'm going to be joining my Medic Academy to do houseman assessments session for internal medicine this 15 this weekend. So if please join us. For those who's keen, you can actually join, have a look at the Facebook of My Medic Academy. Right. With that, let's have some questions. Thank you very much.
Okay, thank you very much, Dr. Rafidah, for the crystal clear presentation. Actually, I also learning a bit about, actually not a bit, a lot about this, especially when you say that actually the EC changes doesn't correlate based on the severity of hyperkalemia. That one is very interesting, Dr. Rafidah.
Yep.
So there's a few questions here in the chat box. Actually, most of the questions actually you already explained. However, we just go through back one by one, Dr. Rafidah. Okay, from CS Chai, after post-ACE inhibitor or IRB, there are several thoughts of when should check renal function test. Some old literature suggests 7 to 10 days. Our CPG said within 14 days. KDIGO suggests for more frequent for those who are at risk. What is your comment about this? Thank you.
Okay, actually, a lot of people misunderstood our CPG. It's actually within 14 days. So 7 to 10 days, it will be just nice. It doesn't need to be 2 weeks. So I don't know why the misunderstanding and misconception of 2 weeks is. I'm sure you understand that way as well, right?
Yes, yes.
Yeah, so it's not. So it's actually around 7 to 10 days. In fact, if you start ACE inhibitor, going back to the ACE inhibitor story, if you start ACE inhibitor in the hospital, if the patient is there for 5 days, you can just check the RP and that's it, right? It's fine. That's another one. Another statement I want to make is ARB. Most of the patients I see as well, when they come into hospital with acute heart failure, acute fluid overload, this is not the time to start ACE-ARB, because they will, at that point, they are very unstable. You start ACE-ARB when patient is stable, not when they are unstable with fluid overload and all these things. Of course, they will get AKI eventually. So at that point, we're not sure whether it's the ACE inhibitor or what, right? So my take on ACE inhibitor, you have to start it when you're stable as well. Yeah.
Okay. The next question is from Hong CM. Doctor, for hypokalemia, when do we prescribe oral KCl and when do we give potassium through IV?
Okay, so good question. So I would say severe hypokalemia. And I'm thinking it's hypo, kan? Severe hypokalemia is less than 2.5. I will give IV, of course. But if it's less than, I know cardiologists have got different stories. I don't understand. Maybe you can tell me. This is from cardiology point of view. But for renal, okay, severe hypokalemia will give IV. So for example, kalau potassium dia dah 2.679 nak cepat sikit, we can give another IV, for example. So that's for us. After that, it's just oral. Again, depends on the cost lah. Yeah. What cardiologists want the potassium very high, you know? I don't know why.
Yeah, actually, for those all arrhythmia, they want more than 4. They prefer one. No, actually they say this is it can actually prevent the patient from get VT lah, ventricular tachycardia. So that's why they prefer the potassium more than 4.
Itulah, I'm just wondering whether it's evidence based or not.
Okay.
Putting you on the spot here. It's not nice. Sorry.
Okay, so we proceed with the next question from Chan Fung Singh. Doctor, for the refractory hypokalemia, asymptomatic, potassium about 3. On slow K daily for a year, no medication that cause hypokalemia. How would you manage if happen all the blood investigation for hypokalemia happen to be normal? What would be the next step?
Right. Okay. So for if you have hypokalemia, right? So asymptomatic hypokalemia, you really have to look for renal tubular acidosis. You look for the acidosis. Maybe just the potassium is not enough. Maybe you need to give your the Scholl solution, kan? Maybe there's acidosis there. You need alkali punya this one. So basically, you have to investigate. You have to do your urine pH. You have to, of course, you've already ICU, you've done all the thyroid function tests and all these things, can. And what's common is actually the patients not taking your tablets. Actually, they are very common. I don't know if your patients are good, I guess. But my patients, you know, the RTAs, the hypokalemia, they're very asymptomatic. They don't take. They don't want to take. It's not nice. Yeah,
That's right.
Yeah, so that's probably the reason, lah. Yeah.
Okay, next question from Haziq. Doctor, for case 2, let's say she's going for a contrast radiography. We still should cover the patient with tablet NAC, right? Okay.
Okay. This is a tug of war between us and radiology, like forever. So I'm always I'm a person who don't play defensive medicine. If the patient needs CT scan, the patient needs CT scan, right? It doesn't matter. And worsening renal function from contrast, not common actually, right? So the reason why they have renal failure is probably because of the sepsis itself, right? Okay, so the answering that question is actually we don't use NEC anymore, and there's no evidence of using NEC anymore. So the only evidence that is just good hydration. That's it, right? I never, in fact, my radiologists have been great. They've accepted that, you know, and probably I you know, a little bit of shouting there, but you know, they've accepted that we're not using NEC. They've accepted, I know this is a struggle. They've accepted that nephrologists do not need to be informed the patient needs a contrast. You know, patient's dying, for example. Why would he call me in the middle of the night? You know, you need CT, you need CT. So the short answer is no. There's no evidence anymore. And in my practice, thankfully, the radiologists have accepted it, and the pharmacists have stopped. I think the pharmacies have stopped stocking at NAC oral dekat pharmacy kat luar tu. Of course, you can get it through KPK, but we've stopped doing it already. So I think everybody should stop doing it also.
Yes. So next question from Chu Min Min. Good evening, doctor. When do we say it is refractory hyperkalemia and indicated for dialysis? After how many trials of medical treatment?
So I think I mentioned a few times, everybody should be individualized treatment. So I did say I would go not beyond 24 hours of regular 4-hourly medical management. But if of course, if a patient who's coming with, you know, sine wave, potassium is 9, 8, you can't wait lah. You have to dialyze. I've had a patient whose potassium is 9. And straight away, I brought the patient to, let's say 9.5 or something, even 10. Tak ingat lah. Dah ECG dah gitu-gitu dah. So, you know, zaman-zaman dulu terus masuk femoral, suruh my staff switch on the HD machine and terus sambung. So, yeah, he survived. But, you know, so the answer is we don't know. So usually I will, number one, find out why. Okay, say the cause is because of end-stage kidney disease, for example. There's no way the potassium is going to turn. Okay, say for example, just now I was saying my patient who took creatinine of 200 go and take binge of durian pula. So I was hoping that the potassium will come down, but it didn't. It still stayed about 7, so we dialyzed him. There was a couple that actually do not need dialysis after 24 hours of medical management. So it really depends on the case and individualized and the cause of the hyperkalemia. So it's difficult to have a straight answer for that. Yeah.
Okay. Next question is from Fatima Hasman. For ESRF patient who is on regular dialysis but really keen to eat durian, so is it okay for the patient to have some durian during dialysis? During dialysis, before dialysis, okay.
Right. Okay. So it's a very good question. I don't stop my patients from taking durian, to be honest. I mean, we are living in Malaysia. We have to be, you know, we have to be fair to them. I usually give them substitute, you know, that's it. Okay, her question is more, if you give during dialysis, is it much better than taking it without dialysis? Okay, if you, what I didn't show you, there's a rebound hyperkalemia, rebound potassium tau lepas dialysis. So it doesn't matter lah, you ambil bila ke, apa ke, you know, the best is to tell your patient in moderation. Take it in moderation. Jangan binge. So that would be the best lah. I mean, I've never stopped them from taking durian, to be honest.
Okay. So next question is from Chu. The first one actually you already answered. The second one, does sodium bicarb part of medical management of hyper-K? When we consider to give sodium bicarb when patient having hyperkalemia?
Thank you for the question. I think it's when there is acidosis. Otherwise, it doesn't work. So if there's acidosis, you neutralize it, the potassium will go back in the cell. But again, that is also temporary, 3-4 hours, and then you have to see what happens.
Okay. So next one is from Jia Q Teo. Doctor, for a patient with history of hypokalemic paralysis, discharged with tablet slow K, for how long the patient need to be continue the slow K? This one is up to the causes lah. If
I think if the hypokalemic paralysis usually is RTA, kan? So
yes.
if RTA is lifelong.
Lifelong. Okay. So this one from Haja Amalina. Dr. Rafidah, is hyperkalemia is absolute contraindication for blood transfusion? At what level of potassium that we may allow for blood transfusion? I never heard of this.
Thank you for the question. There is the blood tu banyak potassium tau.
Okay.
So again, I'm not a person who likes blood transfusion, you know. I think we should run away from. I can see a lot of young, you young kan, is young doctors. You young lah kan, young dah berapa?
Young. Still 35.
So a lot of young doctors actually, you know, including you lah, like to give blood transfusion. In fact, in ischemic heart disease, there's no proven level actually. What you should aim at. To me, blood transfusion is not necessary. But if possible, avoid it. Okay, so if you're talking about hyperkalemia and blood transfusion, so generally, I think you're talking about end-stage kidney disease when they present with anemia and hyperkalemia, especially when they present in the middle of the night. Okay, so I would tend the anemia is chronic, right? If they don't have problem, why do we need to transfuse blood? Is the best management would be erythropoietin, intravenous iron, and this and that. So there's no the short answer to that. There is no depth level lah, right? There's no level. But if you need to transfuse blood, I would say if I have a conservative care patient, right? Kalau patient tu tak nak dialysis, if she's running at a HB of 6.5, I would be cautioned to give her blood. I'll be more towards erythropoietin. So you understand the difficulties there, you know. So something like that lah. No direct answer again. I don't like giving direct answer. I always make answer questions so that you can all think again.
Oh, it seems like JQT asking a lot of questions. Very good. So, doctor, in case of elderly with underlying heart failure and CKD, is spironolactone advisable for this patient? Patient also on 18 meter, however, potassium is within normal range.
Okay, so the question, thank you for the question. In case of the elderly, ini heart failure di area you nak bagi Entresto lah.
Yeah. Okay. Tapi yang untuk heart failure, actually you guys just need to give a very low dose, 12.5 also enough. No need to get the BP punya effect. But in CKD patient, I think Dr. Rafidah maybe can comment about it.
So in CKD patient, very elderly, please, you know, I don't know what else you're gonna prevent. They're elderly. The last thing you want is hyperkalaemia. I'm gonna tell you a sad story. I'm gonna tell you a sad story. I had a patient who came in to Sari ward, right? She's got chronic disease and she was given spironolactone, right? And she has severe hypokalemia. She's not a good patient and she's very clearly, she doesn't want dialysis and the family doesn't want dialysis. And the daughter came from somewhere, haven't seen her for a year, right? Because of COVID. And now she doesn't want dialysis, he doesn't want dialysis, she doesn't want dialysis. So she's stuck in Sari ward. So So I did give medical management of hyperkalemia, but you know, it didn't work lah, 24 hours, and I let her go home. But actually, she survived for a week after that.
Okay.
So that's how bad spironolactone is in elderly, especially in the setting of renal failure. So when you have renal failure in elderly, you have heart failure, you have fluid overload. I think the least you could do, you know, your blood pressure is probably not that high anyway. And you know, how much are you going to save? What are you going to save? You know, and to end up what she had gone through, it was really sad. So we don't want that. She was actually 78, but she passed away about a week later at home with the loved ones. And you know, I like palliative care, so
Yes. It's
that's
your
what.
specialty. Yeah. Okay. Next question from the Facebook. Now we're going for Facebook question for Yeshos Swaraj. After we give a medical treatment for hyperkalemia, when do we repeat the serum potassium?
So the guideline says 1 hour after. Not guideline, our protocol lah. I'm sure it happens everywhere. But, right, there's a but. Now, if the patient is in a COVID ward, you have to think about your strategy, right? You want to do that regularly. So what I always do is, again, I mentioned just now, if I know the potassium is not going to come down over 24 hours, I won't bother repeating. You know, I would just do 4-hourly for a couple of times. Tomorrow I'll see, and if potassium is okay, that's fine. For example, recently I had a patient who had tumor lysis. I know the tumor load wasn't that much. The potassium was around I think 6.2 or something like that, and the kidney function was still okay, and he was passing good amount of urine. And I just said, look, you know, she's in Sari ward some more. I just said, look, let's do 4-hourly, 3-4 times, and then see tomorrow how it is. Which, true enough, tomorrow is normal. So, you know, it sometimes needs a little bit of clinical judgment. But but the guideline says 1 hour after lah. Somebody's going to kill me otherwise. Yeah.
Okay. We go for the last question. This one from your dear friend, Dr. Fat Zakaria.
Boleh jawab ke?
What about giving potassium sparing with kalimate daily for the benefit of the medication, especially in poor ejection fraction patient?
And what ejection fraction? You should answer that question, not me.
I can answer, but without CKD lah. Yes, I can answer that.
So there are potassium sparing means spironolactone lah. Okay. So I don't know how good is spironolactone evidence based in terms of heart failure.
For heart failure, actually, actually it's a consensus from the expert consensus. It shows that there's reduced mortality. However, the dose you just need to give a very low dose. 12.5 is enough. No need up to 25 or 50. Just a minor, very minimal dosage is enough to reduce the mortality. This is the research that they did lah. So, but most of us actually they try to increase to optimum. They thought it's like beta blocker and azimeter, ORB. They're giving the highest that they can, which is wrong.
Yeah. So Dr. Fadlina, I rasa HPM banyak duit boleh beli Entresto tak? Sorry. Ada iklan pula ni. So I mean again, it's seriously, it's my mind je. Seriously, it's actually a risk benefit ratio. I mean, if you really seriously think about the benefit of spironolactone, it is like, you know, outweighs the risk in your patient, I don't mind giving. But, you know, of course, with you know, if you want to give a chronic kalemia has been shown not to be, you know, the long-term effect also is questionable if you do it daily, you know. But again, you have to look at clinical, discuss with the patient and then decide what's best for them. It's a bit odd giving, you know, kalimate and spironolactone. But if it's a good patient who's going to follow all your orders and not take dietary binge of durian, I think you'll be fine. right? So again, it's a shared decision with you and the patient, and decide what's best to proceed for their clinical, presentation. Kan, is.
Yes. Can we do another one, last one, Dr. Rafidah?
Boleh.
From Facebook. Okay, from Izuddin. Doctor, do you have any comment on patient that is prescribed with ketosteroid tablet? I mean, what patient will be most benefit with this? And in terms of patient with hyper or hypokalemia, better to stop or continue?
I don't think the ketosteroids got anything to do with hyperkalemia issue. But I've got quite a lot of patients on ketosteroids, but the evidence is it's there. But to take ketosteroid is not easy. They're huge tablets, unless they produce nice small ones. But the dietary component that has to come with the ketosteroid is not easy. It's a very, very low protein diet. So a lot of patients give up not taking it, not doing it. My own mother, she was end stage and she refused to take it. Yeah, so because of the dietary compliance to the low protein with the ketosteroid is very, very difficult. But I don't think there's anything, it's not a problem with end stage kidney disease patients now.
Okay. I think there's a lot of questions already being answered by Dr. Rafidah. So we're going to stop here now.
I'm going to share the QR code. Good.
Sorry, the QR code.
So you close, nanti I share balik QR code dengan tu.
Okay. Wait, Dr. Numan boleh close ya, Dr. Numan?
Ya, bukan close. I nak share balik QR code. Nak closing remark tak payah
ya, wait.
Okay, thank you.
Thank you very much, Dr. Rafidah, for the very fantastic presentation about medical management of hyperkalemia. I hope that everyone understand now that what is the correct term and how to prescribe the treatment and when you should prescribe the treatment. It's very important, especially for the houseman, medical officer. Okay, I hope that this session really benefit you guys, and thank you again, Dr. Rafidah, for the excellent talk. Hope that we can meet again. Next will be on 22nd with Dr. Alza regarding CPR updates. Hope you guys can join us for the next session. Thank you very much.
So I'm going to close with the QR code. Thanks, guys.
Okay.
This is the QR code. You can use it on your it's not on the MMA punya, but it's just take a picture of this QR code and then just register your name and so on.
Okay. For those who can't scan the QR code, you can follow the link the one that I share in the chat box.
Sekejap